Good afternoon. I'm Stephanie Maselli, a media officer with the National Academies of Sciences, Engineering, and Medicine. Thank you all for joining us today for a public briefing for the recently released report, Leading Health Indicators 2030, Advancing Health, Equity, and Well-Being. The slides and recording of this webinar will be available next week at nationalacademies.org and also at nap.edu/25682. Once again, that's nap.edu/25682. There you can download the report and related resources. You can also follow the social media conversation at #LeadingHealthIndicators2030. For those of you who are not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, we are private, nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. For each requested study, panel members are chosen for their expertise and experience, and they serve pro bono to carry out the study statement of task. The reports that result from the study represent the consensus view of the committee and must undergo external peer review before they are released, as did this report. I have with me two members of the committee to discuss the report, but before I introduce them, I want to go over a few reminders. Please note that this webinar is scheduled to last 1 hour. We'll start off with a presentation summarizing the report by the committee members, and then we'll open it up to any questions you may have. You can simply click the Q&A button on the bottom of your screen to submit a question. And if you have any technical issues during this webinar, please contact Zoom technical support at 1-888-799-9666 and select option 2. Now I'd like to introduce the members of the committee that wrote the report who are here with us today. We have George Isham, who is a senior fellow at the Health Partners Institute, who chaired this committee. And we have Sherry Johnson, director of the Population Health Institute at the University of Wisconsin-Madison School of Medicine and Public Health. And with that, I'd like to turn it over to Dr. Isham.
Thank you, Stephanie. And I'm George Isham, and as Stephanie indicated, I'm joined in this webinar by committee member Sherry Johnson. The committee appreciates having had the opportunity to assist the Department of Health and Human Services by providing advice on a key aspect of its important Healthy People 2030 effort. Sherry and I will be providing a briefing on the findings and recommendations of our report and respond to your questions and comments following our brief presentation. Next slide, please. There we go. The members of the committee are listed here and represent the diversity and depth of knowledge and expertise important to making recommendations of the leading health indicators for Healthy People 2030. It's been a pleasure working with them on this report. The development of Healthy People 2030 and this committee's work that recommends leading health indicators comes at a particularly critical juncture in the approximately 40-year history of the Healthy People effort. Our understanding of those factors leading to health has deepened and expanded over these past decades so that we are now more fully understanding the importance of social and economic factors relative to healthcare and historically traditional prevention and public health efforts in producing health and well-being. Among the estimates that the committee evaluated, the county health rankings model, for example, assigns relative health impact weights of 40% to social and economic factors, 30% to health behaviors, and only 20% to clinical care, and 10% to environmental factors. The committee sees the Healthy People Initiative as a high-impact, high-visibility resource for educating a broad cross-section of Americans, including healthcare professionals and more importantly, members of the public more generally, who typically look to curative medicine rather than social and environmental factors as critical determinants of health and well-being. Our committee feels strongly that the time has come for Healthy People effort to more substantively reflect these important developments in our understanding of what creates health and well-being. This slide represents our understanding of the timeline for Healthy People 2030 and where this committee's reports and advice fit into that timeline. It's important to note that our work on these two reports occurs after the draft Healthy People 2030 objectives were released by the Department of Health and Human Services, but before the department will release the final Healthy People 2030 objectives later this year. In our first report, released last year, we addressed the criteria for selecting leading health indicators. In this second report, we make our recommendations for Healthy People 2030 leading health indicators. Not having the final Healthy People 2030 core objectives was a challenge and affected our approach to the charge, our recommendations in our first report, as well as the leading health indicators recommended in this report. We were very pleased, however, that this afforded us the opportunity to nominate leading health indicators that came from outside the initially available draft objectives. Next slide, please. The committee found this Healthy People 2030 framework graphic, which was formally adopted by the Department of Health and Human Services for the Healthy People 2030 effort, inspiring, a key touchstone, and a guide for our deliberations on criteria in the first report, and in this report on our recommendations for leading health indicators. We were particularly pleased to find that along with health, the importance of well-being across the lifespan is featured prominently at the center of the Healthy People 2030 framework. This is shown as having physical, mental, and social dimensions. We like that the key role of cultivating healthier environments, physical, social, and economic, increasing knowledge and action, including promoting shared responsibility across sectors, enabling public health successes, ensuring the enactment of evidence-based laws, policies, and practices, and driving action with objectives and data, and closing gaps, including, importantly, health disparities, health equity, and health literacy, are all depicted as important to achieving health and well-being across the lifespan. We think that the intertwined strands featuring actionable data, evidence-based interventions, and strategic resources are very important enabling factors. We found these themes and sub-themes useful in considering balance in our list of recommended leading health indicators, and also useful as a checklist of sorts for the portfolio of recommended leading health indicators. Next slide, please. To briefly review, our first report was delivered last year and informed the work of this second report. We found that Healthy People 2030 draft objectives were missing key topics, that in order to align objectives with the Healthy People 2030 framework, additional objectives were needed. Too few objectives that allow international comparison were available, and we felt that international comparison was important in benchmarking the nation's progress. We found that existing LHI criteria, if applied to the draft objectives, would not result in a portfolio of leading health indicators that would fully align with the Healthy People 2030 framework. We therefore recommended that new objectives be added, which we have done and are included among our recommendations in this second report. We recommended a three-phase process for leading health indicator selection that would add alignment with the Healthy People 2030 framework itself, which we termed as a phase 0, in addition to applying phase 1 and phase 2 criteria proposed by the Secretary's Advisory Committee. Our committee agreed with what the Secretary's Advisory Committee recommended and endorsed that approach. I will show you those criteria in a few slides. Next slide, please. In terms of arriving at the leading health indicator set, our process consisted of generating a list of leading health indicator candidates consisted of 5 steps outlined in detail in the report. To summarize, our approach invited the committee to review established reference measure sets to proposed candidate leading health indicators that reflected the Healthy People 2030 framework. I'll show you those here in a minute. Our approach also harvested candidates' leading health indicators from the draft objectives that fit the priority topics identified by the committee. Wherever possible, leading health indicators were drawn from the draft objectives in preference to developing new objectives. As mentioned previously, the key to this approach were our findings from the first report that existing draft objectives were missing key topics and lacked an appropriately balanced and comprehensive range from which to derive leading health indicators that also reflected the intent of the Healthy People 2030 framework. Next slide, please. This then is the table of the reference measure sets that we consulted. And I realize it's a little difficult to read on the screen. I'll give an overview of some of the highlights. We reviewed the existing frameworks and other graphic representations of the social determinants of health. We gathered well-known, validated sets of measures to expand the existing draft objectives and measures and place a broad array of potential measures that more fully reflect the Healthy People 2030 framework at the committee's disposal. The committee's resources and timeline did not allow for an exhaustive or systematic literature review, but the committee and staff worked together to assemble a good list of reference measures. We looked to respected reference measure sets that are listed here in the table from both domestic and international efforts to characterize health and well-being. Our aim was to make sure that among the leading health indicators were measures that permitted international comparison, as well as measures that were useful to local communities and governments. Some of the reference measure sets that are included on this slide include county health rankings, America's health rankings, well-being in the nation measures, 2011 Institute of Medicine report on 2030 leading health indicators, 2020 leading health indicators rather, the OECD or Organization for Economic Cooperation and Development measures, the 2015 Institute of Medicine Vital Signs report, Healthy People 2020 leading health indicators, the World Health Organization 100 core measures, U.S. Department of Health and Housing and Urban Development Healthy Communities Index, and the Bay Area Regional Health Inequities Indicators. This is not an exhaustive list, but it indicates the breadth of what we considered in generating our list. Next slide, please. Selection criteria that are depicted here on the slide, which is a summary listing of those criteria that the committee applied in arriving at our recommendations for LHIs, can be found in a more detailed form in the report itself. In the right 2 columns on this slide are phases 1 and 2 criteria that were recommended by the Secretary's Advisory Committee, and given our agreement with their excellent work, we adopted them without modification. Phase 0, which we proposed be added to those phase 1 and phase 2 criteria, are listed in the leftmost column. This column outlines the components of the Healthy People 2030 framework, and we felt this was very, very important, that we would be guided by in every step of the process by this framework, and felt it was important to include it as an initial step in identifying leading health indicators as described in report number 1. Next slide, please. So I'll turn this over to Sherry at this point. Sherry?
Thank you, George. So in this report, we recommended a slate of 34 recommended leading health indicators, and we made 4 findings. Finding 1 relates to early childhood care and education. Findings 2, 3, and 4 relate to costs and investments in public health and healthcare. Over the remaining slides, we will comment briefly on considerations related to well-being and equity, offer brief comment on how we sought balance in the set of 34 LHIs that are recommended, and then present our list of recommended leading health indicators. We will follow the presentation of the candidate leading health indicators with a brief discussion of the 4 findings and then conclude with your comments and questions. Next slide, please. The Healthy People 2030 framework provides a new paradigm for organizing the tracking of objectives and leading health indicators. The leading health indicators we recommended are intended to reflect the framework's vision, goals, and foundational principles, which are the themes and sub-themes you saw in the framework graphic. Well-being, a broad concept included in the graphic, speaks to the many facets of an individual's life, physical, mental, and social, which were first articulated in Healthy People 2020 as an individual attribute, but expanded in Healthy People 2030 to include social or community well-being. The World Health Organization discusses well-being as having two dimensions, objective and subjective, comprising individuals' experience of life circumstances in the context of social norms and values. Health and well-being are seen as interactive, whereby health influences overall well-being and well-being affects future health. Equity is also a core concept in the framework, and achieving equity is both a foundational principle and one of the 5 overarching goals of the Healthy People 2030 framework. Health equity is defined in Healthy People 2030 using the Office of Minority Health definition. And that definition indicates that health equity is defined as the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historic and contemporary injustices, and the elimination of health and healthcare disparities. The committee drew on other resources and definitions to reflect on health equity as well, including Braverman et al.'s 2017 definition in the Robert Wood Johnson Foundation brief, where they define health equity in part as everyone having a fair and just opportunity to be as healthy as possible. Applying an equity focus to the leading health indicators means that we must go beyond disaggregating measures by demographic categories, which can tell us about disparities. An equity lens, however, requires that we identify and include leading health indicators that identify structural barriers such as neighborhood circumstances and policies that create unfair advantage. Next slide, please. As discussed previously, we sought to balance the recommended leading health indicators set by considering a number of issues. We sought balance by the themes and sub-themes of the Healthy People 2030 framework, as already discussed, by the ability to more proportionately reflect the impacts of the non-medical determinants of health, by the ability to make international comparisons. More than a dozen of the recommended LHIs in our report can be used for this purpose, by the ability to make comparisons at different levels of government or analysis, local, state, and national, for example, by the ability to more robustly reflect the emphasis on well-being, equity, and disparity. Balancing the LHI set included also attention to the life course and having measures for different age groups. Although for some leading health indicators, the committee was interested in particular in measures that could be tracked earlier in life for the potentially greater impact that would have over a life course. Next slide, please.
And I'll take it back from Sherry at this point. So the next 3 slides are the list of our list of 34 leading health indicators that we recommend. A bit of orientation to the tables is appropriate. For each of these slides, those in blue type on the chart are drawn by the committee from outside of the list of draft objectives and list a brief title in the first column and our committee's proposed objective statement in the second column. There are 15 of these leading health indicators. Please see the more complete information than we will present here on these leading health indicators with their proposed objective statements in the report text. Those in black type on the slide are drawn from the list of draft objectives, with its brief title in the first column and its alphanumeric designator and objective listed in the second column. There are 19 of these leading health indicators. Sherry and I will now walk through these 3 slides, this one and the following 2, and highlight some, but not all, of the proposed leading health indicators with brief discussion. Those that we will discuss are shaded in yellow on these tables. So as you can gather then, the yellow on this table indicates that we will discuss life expectancy and child health. Sherry?
Thanks. So the first one we'll highlight is life expectancy. The committee thinks that life expectancy is important as a leading health indicator because it's a broad summary indicator of health. It is important to track as an LHI because of international benchmarking and as an indicator of geographic, racial and ethnic, and other social dimensions of disparity. Recent decline in life expectancy in the United States is a major public health concern, and as a leading health indicator, setting an objective with established targets would be particularly helpful in setting the nation on a path toward learning what we need to do to improve this key leading indicator of health. The committee felt strongly that our country can be as healthy as other OECD countries and valued the opportunity for international comparison. The second one to highlight on this slide is child health, and we propose a measure of adverse childhood experiences. 2 decades of research support the value of tracking these key childhood exposures in order to intervene and change the trajectory of outcomes. Although we recognize ACEs represent a large set of issues, there's a great deal of evidence about the pathways between the range of childhood traumas and effects on development, health, and well-being. Moreover, there's robust evidence to show that interventions that prevent adverse childhood experiences, or ACEs, in childhood could reduce the prevalence of chronic conditions, risk behaviors, and other health outcomes in adulthood. Next slide, please.
On this slide, we highlight 3 for discussion. Mental health is the first of those, and this measure attempts to capture a broad range of mental health issues and is used in multiple well-known measure sets, including the county health rankings. The 8 draft Healthy People 2030 core objectives do not include any general measures of mental health. The frequent mental distress measures could offer a measure that provides a broader sense of mental health in the population at each level of measurement, both local, state, and national. The objective can help address equity and disparities if the data is disaggregated by race and ethnicity, among other demographic categories, and could serve as a bellwether given the worsening mental health in some populations. The second one we'll highlight on this slide is one drawn from the draft objectives, and it's the hypertension rate. We wanted each of our indicators, if possible, to cast what I would term as a broad wake. For example, hypertension. Hypertension is potentially a serious health condition itself, a key risk factor for major causes of mortality and morbidity, among them cardiovascular disease, stroke, and kidney disease. Hypertension is prevalent in the population. It is amenable to treatment and can be affected by behavior change. Hypertension is amenable to public health interventions. Hypertension control is amenable to healthcare quality improvement interventions. Hypertension control is also an indicator of quality healthcare. Hypertension rate, therefore, is a good example of an LHI that can capture or be associated with many issues that can often be considered as a proxy for other chronic diseases. The third issue on this list, the leading health indicator on this, is ambulatory care sensitive conditions. Hospitalizations for ambulatory care sensitive conditions have been used over the past 25 years at state, national, and international levels to track hospital discharges for illnesses that can be prevented through access to high-quality primary care. The committee endorsed these as an LHI, given their ability to capture access to quality as well as its quality. The access to care as well as its quality. The committee recognized that in covering both of these important areas, it is an aggregated measure that flags problems as well as progress in the quality of outpatient care available to Americans. It is used by Medicare currently and could be tracked at state levels through Medicaid data. Given the need for parsimony in identifying a set of leading health indicators, the committee felt that ambulatory care sensitive conditions were a high-level indicator that better captured the experience of the quality of outpatient care than did, for example, the receipt of clinical preventive services. Given committee concerns about the opportunity cost of our expensive healthcare delivery system, which we discuss in a bit here, we noted that substituting a high-quality outpatient care for hospitalization is an important break on the expensive and the costly healthcare system. Next slide, please.
On this slide, we'll highlight also three LHI candidates and measures. The first is the Environmental Quality Index. The committee appreciates indexes because they're composites and offer efficiency when parsimony is desired in the LHI set. We selected the Environmental Quality Index, which has been developed by the U.S. Environmental Protection Agency as a leading health indicator. It brings together 5 key dimensions of exposure: air, water, land, built, and sociodemographic environments. It's available at local, state, and national levels, and public health agencies can reproduce this index from locally and nationally available data. A deep and growing evidence base assessing the relationship between environmental exposures captured by the EQI and their effects on mortality substantiate the index's utility as a sentinel for population health. Additionally, there are well-documented health disparities in environmental risk exposures, exerting an undue burden on specific populations. The second measure for the environment that we propose as a leading health indicator is the Heat Vulnerability Index. Given the science indicating that climate change has an array of threats to human health and well-being, the committee thinks that climate change is a timely and important indicator. The Lancet Countdown to Climate Change and other scholarly sources offer a range of robust measures of the health effects of climate change. Of the available measures, the committee notes that the Heat Vulnerability Index can be used for preparedness. Areas with a high heat vulnerability index could use that information to prepare for and to prevent mortality and morbidity, for example, by deploying cooling centers, checking on isolated elders, and other types of interventions. The Heat Vulnerability Index's geography and demographic dimensions are actionable in the sense that they can inform planning and preparation. The third leading health indicator on this slide that we'll highlight is measures of residential segregation. The index of dissimilarity was selected as a leading health indicator, and it measures how evenly racial and ethnic groups are distributed across geographic areas. Research has demonstrated that neighborhood-level segregation affects economic opportunity. Segregation has been considered a key determinant of racial and ethnic inequities in health. For example, one study has shown that changes in segregation were associated with changes in systolic blood pressure over 25 years. Specific to the index of dissimilarity, dissimilarity has been linked to the unequal distribution of local and municipal resources, as well as exposure to environmental toxins. Next slide, please. The committee has 4 findings, as we discussed previously, and I will now discuss finding number 1 related to early childhood care and education. The committee recommended 4th grade reading level evaluation as a critical leading health indicator with which to alert the public and galvanize action toward improving educational outcomes. Children who are falling behind by 4th grade are less likely to graduate from high school and be successful academically. Disparities in health outcomes by educational attainment are well documented. Had there been availability of an indicator that tracked the quality of early childhood education, the committee would have preferred that, given evidence of how quickly young children fall behind. Quality early childhood care and education is key to school success, but the committee was unable to identify an adequate measure. Thus, the committee finds that a developmental objective of access to quality early childhood care and education could draw attention to the importance of starting early and placing children on the pathway to 4th grade reading proficiency and other measures of educational success. Next slide, please.
So I'll discuss,
yes,
thank you. I'll discuss findings 2, 3, and 4, all of which relate to resources and cost. The committee deliberated at length about healthcare cost, a topic that falls under healthcare access and quality sub-theme on the Healthy People 2030 framework. Excessive spending on healthcare cost has opportunity costs, robbing financing from other important social investments, such as education, public safety, and so forth. Our deliberations were informed in part by the 2012 Institute of Medicine report that noted that U.S. healthcare spending far outpaced that of peer nations, while U.S. measures of health outcomes, for example, life expectancy, were mediocre. The consensus committee recommended setting a goal for life expectancy and for per capita spending that would approach the average performance of other affluent nations. So the committee, working with that previous recommendation, identified a number of challenges in finding a leading health indicator with which to track healthcare spending. In short, aggregate spending is minimally informative about the extent of overtreatment, spending too much without health benefit in some areas or populations, and undertreatment, spending too little for effective care in others, or excessive prices relative to other high-income countries. In lieu of selecting a leading health indicator to cover this area at this time, the committee recommended 2 areas that could prove useful for development in future leading health indicators and future editions of Healthy People. Regularly tracking a market basket of pharmaceuticals for comparison with prices with other OECD nations. A study of that nature was conducted by the Department of Health and Human Services in 2018, and tracking administrative costs, which in 2016 averaged nearly $800 per capita in the US compared to with $100 per capita in other OECD nations, were the 2 areas we thought might prove fruitful for future investigation. Aware also of the failure of many regions to support adequate public health infrastructure, the committee recommended that a reliable approach for tracking per capita public health spending be developed and monitored such that the differences across states and localities become transparent to decision makers and the public at large. Adequate public health infrastructure is important in dealing with public health emergencies, as well as promoting the health of communities and realizing the full potential of both individuals and populations in our country. So hence, we've covered 3 areas for 3 findings which outline 3 areas for potential future development: the market basket of pharmaceuticals, the healthcare system administrative costs, and per capita public health spending. Next slide, please. I wish to thank you for listening in, and I want to make a comment that we really appreciate. The committee really appreciates the opportunity to assist the Department of Health and Human Services by providing advice on this key aspect of this important Healthy People 2030 effort. The Healthy People 2030 has at its core all of us working together to improve health and well-being. It's a privilege to have had the opportunity to be part of and to contribute to the success of this effort. Sherry and I will be happy to hear your comments and respond to your questions, and I'll turn this back over to Stephanie, who will moderate the question and answer period. Stephanie?
Thank you all, and we'll now open it up to questions. Just to kickstart the conversation, our first question is, what should the general public take away from your report?
Well, let me start a reply to that, and I'll let Sherry add to that. First, it should take away the set of recommended leading health indicators, which I think provides a broad portfolio of items that can more fully characterize the Healthy People 2030 framework as it leads to health and well-being. So that's obviously the most important part of this is our set of leading health indicators. Secondly, the emphasis in this set of recommended leading health indicators on those factors aside from healthcare that are also important in improving health and well-being is more prominent in this set of leading health indicators. And we've addressed many social factors, including the Environmental Quality Index noted previously, as well as the summary indicator of health of life expectancy, which gives that emphasis, among others. So I think those are several things we can take away from this report. Sherry, do you want to add to that?
I would add that one of our committee members suggested the analogy that the leading health indicators can be thought of like a doctor's checklist, like during the basic checkup. They're things that we should all be keeping our eyes on as a nation. They're a subset of priority public health objectives. And as George has said, they are a set of indicators that really balance the range of social, economic, and physical environmental factors with factors related to healthcare and healthcare access that we know drive population health.
Thank you. Our next question is, did you consider how these objectives and criteria align with the UN's Millennium Development Goals or Sustainable Development Goals?
We considered a number of sets for measurements and a number of international sets, including the OECD set that I indicated. I am not sure that we looked specifically at that set, however. I could be corrected by Alina if she's on the call, or Sherry if you have a recollection.
I don't think we did look to that set, and I think the time frame with which we had to complete 2 reports limited the number of reference measure sets that we could attend to.
Another clarifying question, child health was broken out as an LHI candidate. Did you consider breaking out senior health as an LHI candidate, especially given that many baby boomers are becoming seniors and there are prevalent issues such as food insecurity among the elderly?
Those are good points. We certainly, as we indicated in our remarks here, wanted to consider indicators across the lifespan. And given the parsimony in the set, gave some preference to indicators that would be applicable earlier in life that would have an impact across the lifespan. So in that sense, we did not specifically address that indicator. Sherry?
Correct. We did include an indicator on disability, which specifically looks at reducing the percentage of adults age 65 and over with limitations in daily activities. But I understand and appreciate the comment about also understanding social determinants for older people.
Thank you both for that. And just to address this person's question, there is an indicator, it's number 30, about reducing household food insecurity. So it's just more broad and doesn't get population specific. The next clarifying question is, could you comment on why ambulatory the ambulatory sensitive condition indicator is limited to the Medicare population only versus perhaps one for Medicaid?
Let's see. We had to consider a number of factors in terms of the development of these indicators, including the adequacy of data sources and so forth. So I can't specifically speak to that, but I think that may be related to why that has why we indicated it in that particular population. Sherry?
I think we also have notes that indicate that it can be tracked at the state level through Medicaid data. So it's possible to track it using both Medicare and Medicaid data.
That's correct.
Thank you. Another question is, why have you listed the age of adolescents starting at 15?
That is an objective that we pulled directly from the draft objectives, and so those draft objectives were written and we accepted them as written, so we did not set the age at 15. George, would you?
I would agree with that. I think it's important to understand that wherever possible, we drew from the draft objectives without doing an independent assessment of all the factors that went into forming those draft objectives. So we wanted to make sure that as much of the objectives that we were recommending LHIs for were based on what was already currently under consideration by the department. So we didn't have a discussion critiquing the various specific aspects of those existing indicators.
The next question is, we didn't see LHIs relating to adult tobacco use. Going back to your analogy of LHIs as a doctor's checklist, shouldn't that be included as well? And have there been any changes given all of the advances and challenges with respect to nicotine delivery in the past decade?
We do have tobacco as number 18 on the list. And we had an extensive discussion about the importance of it and would agree with the presumption in that question that it's important to public health. We have a caveat in the report that indicates that not only should we be considering tobacco, but those contemporary smokeless tobacco vapor kinds of products as well as traditional tobacco products. Sherry, you want to help me with that?
I would just add that I think the life course perspective and thinking about the ways in which we can prevent onset of tobacco use as early as possible, I think was one factor that led us to select this existing draft objective.
Thank you. The next comment is, I appreciate the thorough process you went through. Was there any discussion about including more breastfeeding indicators?
Over the course of our deliberations, there were many, many issues that we could have considered for inclusion among the leading health indicators. And certainly the important issue of breastfeeding is one of those we might have considered. But we fell back on the knowledge that many of these issues would be covered in the full set of objectives that the department would be releasing later. I don't know if breastfeeding specifically will be included in that final set, but we felt that that might be a place for many of these issues. We tried to, in selecting our 34 indicators, deal with the more broad issues rather than more specific issues, so that the 34 indicators would give us a broad indication of those factors that were important to health and well-being. So I'm sure that there are many questions that could come forward about specific issues that we did not include in our list of recommended LHIs. But hopefully many of those critical ones will also be included in the broader set. Sherry?
Don't have anything to add to that.
So now that you've put forth your proposed leading health indicators, what is the next step? When can we expect the final Healthy People 2030 report, and who is responsible for applying these recommendations to the creation of programs or policies?
Our committee was asked to provide advice, independent advice, to the Department of HHS in the process of its development of the Healthy People 2030 indicators and also the criteria for selecting those indicators. And as I indicated on the timeline slide, the department has its work to do in terms of looking at this advice and moving forward to incorporate it or not incorporate it into the final list of objectives and leading health indicators. So from here, the next steps are the responsibility of the Department of Health and Human Services, and I would suggest you approach them for their comment on what those next steps will be. We understand that a list of objectives, final objectives, will be released sometime in the coming year, as well as a list of leading health indicators.
Thank you. We have another question. Does the numbering of the LHIs mean that number 1 is more important than number 18, for example?
No. This is a non-prioritized list.
Okay.
They're all important.
We have another question. Many of these LHIs will involve non-health sectors playing an active role. So how would you plan to engage housing, agriculture, transportation, and other players to fulfill the vision of Healthy People 2030?
Well, we have no plans for that engagement. We were not asked to develop them or further comment on HHS's plans for that. I understand that the Department of Health and Human Services not only has its own staff working on this, but a federal interagency advisory committee, which is drawn from across the agencies of government relating to other sectors. And therefore, one might see that as one way of engaging the governmental sectors. But beyond that, there's a lot of work to be done in terms of engaging the other sectors in this effort, and that belongs with the Department of HHS. And again, I would refer questions about that process to them.
Why did the committee feel that it was important to have 2 different measures of residential segregation?
Sherry?
Yep, so we included 2. We debated also whether to include a measure related to individual discrimination, similar to items that are included on the Behavior Risk Factor Survey. We included it in order to recognize the importance of equity, which is featured in Healthy People 2030 graphic framework, and to make sure that there was a balance of measures and indicators that reflect how we get to equity. And so these 2 measures in particular help us to think about the ways in which resources are associated with residential segregation, and in particular resources that are related to the opportunity to live long and well.
Are you able to speak to how the recommended measures have or have not been validated with often underrepresented and undercounted populations, for example, ethnic minorities, LGBT? And for those that have not yet been validated, do you make any recommendations to ensure that the measures do not inadvertently exacerbate existing disparities and inequities?
Sherry, can you help me with that one too?
From my understanding, the data sources that we are using are all existing data sources. We did not seek to evaluate whether those data sources are valid for different populations. I think that is always an important question to ask. We were focused on thinking about data sources that could be utilized at the national, state, and local level. And so the indicators all pass that test. But there isn't a measure in the list that I'm aware of that introduces a completely new measure that hasn't yet been tested on any of those populations. For example, the Cantrell's ladder has been implemented across many countries and with different populations. So this is not a new measure that has not been tested at all.
I would add to that getting to this point of the 34 recommended LHIs and identifying these issues that hopefully reflect that broad framework that the Department of HHS has really challenged us to really bring to life. There was a lot of work to get to this point, and the work is not done. And a number of the issues brought up in that question in terms of how the data plays out in specific populations and whether there are issues and problems that need to be addressed, I am certain will be on the work list of things that need to get done at HHS in order to bring this to life. So we did not engage with a really in-depth analysis that would suggest addressing some of those issues raised in the question, but I certainly agree with Sherry's comment as well.
Did the committee consider or discuss how some of the leading health indicators might influence one another? For example, this person points out how ACE or adverse childhood experience scores could contribute significantly to fourth grade reading level.
Mm-hmm. That's an excellent point. And no, we did not discuss the interaction between indicators. And I think to George's point, that would be a much more complex task and analysis, but I appreciate the perspective.
I do too. I think there's tremendous insight in that question. And in making a recommended set of 34 indicators, it's probably not inappropriate to consider that many of them may have interactions of the type that are indicated in the question, and perhaps others. And so I think that's also something to keep in mind as we move forward. For example, I would imagine that education level and the ability to afford housing, as well as levels of poverty and food insecurity, might all travel together as well. So anyway, that's a good point. Thank you for the question.
What measurement tools will be used to gather the data for the objectives?
That I am, Sherry, if you have comments.
I think that's an HHS question as well, in terms of, first of all, whether which ones they accept that we recommended, and then second of all, what process and system they use to track progress.
We're generally aware of the fact that on the Secretary's Advisory Committee, the various leaders within HHS that are responsible for various measurement activities have had input and participated in those conversations. And I would expect that obviously they would keep going forward. But Sherry's right. We didn't consider that issue. That's an HHS issue.
We have another question. What is the relationship between the LHIs and the specific HP 2030 objectives? Are each of the LHIs supported by specific objectives?
The answer is yes. And they're
yes,
actually outlined.
And though.
Sorry?
Yes, and because some of the objectives we identified are not included in the draft objective list that's currently available to the public from HHS.
I may have
so the 19, I think that's the question, is there the balance between which ones are represented in the draft objectives and which ones are not.
Could you restate the question
34
for us,
total.
Yeah. Stephanie, could you restate?
Yes. The question again is, what is the relationship between the LHIs and the specific HP 2030 objectives? Are each of the LHIs supported by specific objectives?
So I think the answer is to 15 are based. Go ahead.
Let me take a crack at it. First of all, yes, they are, because for each of the existing, each of the objectives drawn from the a list of draft objectives that the government released toward the end of last year, and for each of those, there is a specific statement of objective. For each of the ones that we proposed that were not included in that set, we include a specific objective. As far as targets, which the question doesn't ask, we did not address setting specific targets within that objective. That is something that HHS will do. That's how I understand the question. Sherry, maybe you can answer it differently if you understand it differently.
I was hearing the question focused on which of the LHIs are related to the existing draft objectives. So I was offering that 15 are based on new objectives that we identified through the reference measure review, and 19 of the LHIs are drawn from Healthy People 2030 draft core objectives.
That's correct. And when you read the report itself, each of the proposed LHIs starts out with a recommended objective statement. And there's considerably more detail than we've covered in this brief webinar on each of the proposed LHIs.
The next one will likely be our final question. It comes from a retired public health professional and environmental activist. So as our environmental issues are increasing exponentially and globally and intersect with other social determinants of health, how was this considered and factored into the slate of LHIs that you proposed?
So
sure.
We proposed two related to those important concerns: the Environmental Quality Index, which was developed by the Environmental Protection Agency and covers 5 areas of environmental exposure, and the Heat Vulnerability Index from the Lancet Global Countdown. And so we hope that that as Sentinel and Bellwether indicators, it helps to focus the nation's attention on the ways that environmental issues affect current and future health of the people.
I agree.
Thank you. Well, it looks like we're coming up at the top of the hour, and that those are the questions we have time for today. We had several people join today's webinar, so I apologize if we didn't have time to get to your question. As a reminder, once you exit this webinar, you will be redirected to our report page. But again, that is downloadable at nationalacademies.org or at nap.edu/25682, and the slides from this webinar will be uploaded online within the week typically. So I'd like to thank our speakers once again, and thank you all for spending your afternoon with us.
Thank you.
Thank you.